Diksha. Over to Krishna Prasad sir for last topic. Surgery is not over. Tackling the post-operative challenges.
Thank you, Navrosh, for me to include this wonderful IC. Probably would have this IC would have been in the premium time, then still would have been a much more useful to all the people across. I thank the entire KSOS for this opportunity. So just Diksha, we are just trying with this micro monovision with the Rainer EME is it's fantastic results actually. It gives a kind of effect of how I have done 1,000+ patients for Presbyon in a laser refractive surgery. Almost EMV lens gives a similar kind of effect with the Presbyon effect. There are first, few of the lens we have been trying just recently started Femtis lens. This is a Femtis lens from Lensar. Actually, these are a sort of EDOF accommodative lens which have to be clipped to the entry capsule, but very expensive lenses. But it has to be combined only with the femtos. But these lenses no glare and halos, but patient will get N5 also 6.6 and N5. But the lens is very expensive. I think both the lens together itself is almost around 1.5 lakhs cost price to us. So that is why not been become popular because of its price. And also Rainer has come with one more spiral lens. It is gaining popular. There are some amount of glare and halos I have tried, but could able to succeed with the N6. So all these lenses probably we may require to if they have to read from the distance. Can you fix for 10 minutes? Can you fix for 10 minutes? No, no, it's 6.26. No, but it will make noise, then I have to finish off. Okay. So, surgery is not over. Tackling post-op challenges. I think Navrosh has been very much in detail. He had told about the clinical judgment, about you need to see the history. There is a history of amblyopia, pinhole vision. You need to look at the color vision and comorbidities like age-related macular degeneration, glaucoma. These are the patients you should never think about all these premium lenses. But these are the few investigations like eye trace and all really handful when you are doing a premium IOLs. Of course, as Jairam said, that pre-op consideration often we missed about to dry eye. We need to treat dry eye, then we should go about with the treatment of premium lenses. Look at the irregular cornea. So always, I think all premium patients, we have to do corneal topography. We have to do OCT, especially to know about epiretinal membrane or early ARMD. And when you're doing with a premium biometer, you'll know even about the whether there is a subluxation or even I think subluxation, or even when you're going with the cataract also you'll know the lens thickness also. So this premium biometry, this biometry with this kind of tools always very much useful, especially whenever you are going for a premium practice, and it's not going to be wasted. So one or two word about already Navras told about the angle kappa. Again, angle kappa is more important when you're treating a hyperopic patients in a laser refractive surgery. So always you should look at the, of course, large angle kappa uh, patients, especially a decentration can happen if the angle kappa is more than 0.7 mm, then you should not put a multifocal. Again, as your study shows that it is not really correlate with the results. But more important in multifocal or premium lens is about the angle alpha, which is the angle between the optical axis and the visual axis. So, which is very important in multifocal lens. Always you should avoid, if the angle alpha is more than 0.6, we should avoid. Of course, these are the angle alpha workup. I am not going to talk, but as I said, that large angle alpha combined with the multifocal, normally patient will have a glare and halos. Then few of us been trying with the aberrometry workup also at 4 mm pupil, 0.3 microns of higher order aberration will produce a blur similar to zero point 0.5 diopters of defocal. So which cannot be implanted. Few of the study shows that higher order aberration more than 0.7, coma which is greater than 0.5, trephile more than 0.4, tetrafoil is more than 0.3, or fifth order aberration more than 0.2. These are the few conditions you should not think about the premium lenses. So today I'll be talking about early post-operative challenges. What are the problems you may have, how we should overcome. Of course, one TAS or end ophthalmitis, nobody even thought about that. Normally, TAS is seen within 12 to 24 hours with a corneal edema. You should always be aggressive with the anti-inflammatory therapy, and normally you should always should have a strict asepsis and instrument care also. Corneal edema, it can happen with the sometimes with a long surgery when you're operating with a grade 4 nucleus. It can be managed by hypertonic saline also, but always whenever depending upon the nucleus, always you should adjust your phacoemulsification, low energy phaco, careful visco use. I think is very very important, and also thorough OVD removal in the end of the surgery, as Jairam said. These are the other challenges he had already told about PCO, cystoid macular edema, and refractive surprise. Posterior capsule opacification can even depend, can one of the late complication you can see, but again depending upon the kind of IOL material or surgical technique. So of course, as early as within a 1 month, a lot of my friends been doing NDAG capsulotomy. Uh, some of the studies shows that use of square edge hydrophobic lenses reduces the PCO, but still I can say that PCO it's a multifactorial. Cystoid macular edema, probably I think post-operative macular fluid accumulation due to the inflammation, typically 4 to 8 weeks after the cataract surgery. So you have to treat with the management with the topical non-steroidal anti-inflammatory drug with the steroids. Even in severe cases, we've been trying with the periocular and intravitreal therapy. So good prognosis, timely treatment is very important. So, refractive surprise, probably it is a failure to achieve the intended postoperative refractive target. So, what will happen if you are having a refractive surprise? It may cause anisometropia. Sometimes it may have a dominant switch also. See, 85% of the should be always less than 1 diopters. So, 55% of the inpatient within 0.5 diopters of target spherical equivalent following a surgery. So now I will talk much about this refractive surprise, because we've been, in spite of sometimes been having a optical biometry of good quality, still you may land with the refractive surprise. Sometimes some problem happen. So if it happens, always, as we know that accurate biometry is very important. Also, selecting the proper IOL formula selection is also very very important, so that to avoid the sometimes wrong lens implantation. So whenever you are having a refractory surprise, so always thorough refraction to the has to be done. Look for any tight corneal sutures, then see for whether lens has put in the sulcus or whether there is a subluxation. So sometimes what happens, the distended capsular bag. That is what Jerome was telling in this one. You should not leave the viscoelastic behind the lens. If you leave, sometimes it can cause a myopic shift also. So also you need to look for any whether any the presence of corneal pathology, whether having a patient is having a corneal edema. That also sometimes influence the refractive outcome. Of course, sometimes post-operative cystoid macular edema also may have a hyperopic shift. So always when you're having this problem, always you should look at the, go back to the biometry where exactly the thing has happened. Then always look for the check the axial length by repeating the biometry. Check for abnormal keratometry whether patient is having already pre-existing keratoconus. Sometimes there is no error, no, then we always attribute it to the something called a effective lens position, and you ELP is so important, effective lens position, it can happen in the other eye also. We have to be mentally prepared for that. So clinical management explain the error openly, and it is not an apology. It is not a declaration that you have done a mistake, but always you should tell the patient openly that this is some of the refractive error has been remained. Just to some of the patients started irritating, if there is nothing wrong in taking the second opinion. But the best option, if you are like in doing nothing, is always the best option, I can say. Many refractive surprise do not require any surgery at all. Sometimes what happen, if you leave behind some amount of low myopia, that may help them for near vision also. Some of the patient already wearing the glasses, they don't mind wearing glasses even afterwards also. They don't feel also. Always you should tell the benefits and risk of further intervention also important. So again, the correcting the refractive surplus depending upon the surgeon's comfort, then how long the lens has been implanted. Of course, the retained viscoelastic, sometimes he can do a early laser eye capsulotomy that allow the anterior displaced IOL to move posteriorly. Corneal refractive surgery we have been training, but always not do before 3 months. Give the eye to settle down. So best option is PRK or someone with the Visumax platform, which can give a lesser pressure on the eye. You can even think about flap, femto flap. Then for you can think, because if you do with the flap, always you can have an option for re-enhancement. So a lot of options been we tried with the wavefront guided treatment, which is the better outcome than the topo guided treatment according to the some of the studies. So always LASIK is safer patient if you do already previous ag capsulotomy. So limitation for laser vision correction normally with the high refractive error, low corneal stromal thickness, and of course extra core. We have been trying out with this with the piggyback lenses. So the advantage when you put a piggyback lenses, you need not have to alter the corneal shape and do not change the corneal refractive power. So you don't require, because you know that to have a refractive machines only me or Jaram can put the machine, but some other people to have refractive machines itself is so expensive. So in such case, I think this add-on circoplex lens really give the very good results. So always you should tell the patient the risk of these piggyback lenses also, because sometimes all these lenses can have a pigmented dispersion also. Then extra cost for the lens you have to bear because it's a bit expensive. This is a one more sulcoplex lenses. Some of the patient after operating monofocal lens, they come to us. Do you have any option? I don't want to wear the glasses. In such cases, we have tried with this kind of sulcoplex trifocal lens, which really gives a very good results. So Naurosh was already mentioning about the dry eye workup. So you have to always, all premium patients, you have to do a very good dry eye workup. But post-operatively, patient can come back to us with a dry eye. So what we do actually, patient with a very severe dry eye, they come to us. We do with like with the moderate severe dry eye, we do the highlight treatment. We start them on cyclosporine, especially the higher concentration cyclosporine like Sequa. We start them 15 days before, then we call the patient for surgery. Even after the surgery, we continue them for a period of 3 to 6 months. Patient will be very happy. Of course, patient, of course, always we have to treat the dry eye. I am not talking much about that, already Navras told. But we know that it's a multifactorial disease. You need to approach multifactorial approach, and you have to resolve the inflammation too. So normally treat with the topical corticosteroid, cyclosporine. We have been trying and giving good results. We combine sometimes nowadays with the patient when they come to us. They might be having a 6/6 vision. They'll tell, I am having a one peculiar pain, doctor. Somehow I could not able to tolerate. This is the one complaint everybody, somewhere pricking. But we have started trying out this lifty grasp and started giving a fantastic result post-op. I think you should see on that. Then of course we have been, those are with the some lid margin difficulties. I think you should go with the doxycycline. So these are the different modules. Always the lot of studies has been showed by Narayan Netralia. All this lubricating with the amount of Trailus combination, that will have an anti-inflammatory effect, that will take care about the dry eye problem. Of course, these are the one problem I think you need to address here post-op, still not, or dysphotopsia. So patient may come to us, especially positive dysphotopsia in the form of glare, halos, starbursts, and light streaks. Some of the patient come to us, I think we have been experienced or something, a senior surgeon might have come with a negative dysphotopsia. So the typical complaint, patient come to you with a temporal dark shadow or crescent shaped peripheral sort of dimming. So these are the things I think you need to tackle them properly, especially for negative dysphotopsia. Not much treatment. Even we have done some of the patient lens exchange also. You need to go for a, sometimes square edge lenses also can cause us in such case, because dysphotopsia itself is a one big full presentation I'm having in my laptop, but that will take around 15 minutes. So you need to think about what kind of lens you use to. Some of the patients sometimes round edge lenses really have a less photopsia compared to the square edge lens. So these are the problem. I think you need to look at the IOLite design, material, high refractive, and pupil size and lens position. Often improve over the time when brain adapts. You should give them the reassurance, very, very important. Sometimes if persistent, you can go ahead with the eyeglasses, changing the IOL type. Reverse optic capture also people been tried, good results. In worst cases, I think you have to do the IOL exchange. So I think IOL dislocation, whenever you are having, I think few of them I have seen, few of my colleagues, when you put a inject a lens, I think lower haptic has been cut. You try to position it, patient will come to you after a couple of weeks that the entire lens don't do like this. Now nowadays you will get a very good IOL cutting forceps. I think Diksha, do my friend Neha has designed such a beautiful IOL cutting forceps which can plug into the phaco machine. You can cut it like a butter within the eye, cut into 3 pieces, you can take out, and in the same setting only you can put the other lens. That gives a better result. So whenever you are having IOL dislocation, you see, I think you have to remove and you should put a better lens. So I'll not talking about. So what are the future directions? As Jairam said that use of femtosecond cataract surgery, perform a key cataract surgery step for high precision. If you want a high precision, I think femto, because some of the patient come to me, they want very next day 6 and 5. I do femto, and whenever if they are having even 0.37 cylinder also, I put LRIs. So that makes next day 6 wow effect. Put them LRIs. I know that these LRIs after a couple of years, the patient may come back to the some astigma, but immediate effect 6 and 6. Of course, for precision, femto definitely will have a better results. Create corneal incision, capsulotomy, lens fragmentation with the laser guidance with the femto. It improves the centering and capsulotomy for better for IL position. Very, very important. Of course, that reduces the fake energy needed pre-fragmentation of the lens. Potential benefits: enhance precision, faster recovery, but limitation, higher cost, we know. So other thing is better biometers for cataract surgery, hydrophobic acryl IOL, there is a lower risk of PCO, good optical clarity, square edge IOL design, mechanically reduces cell epithelial cell migration that lowers the PCO rate, enhanced biocompatible acrylics minimize the inflammation, fibrosis and capsular contraction. We have been using this heparin surface modified IOL that will reduce the postoperative inflammation. Glistening free acrylic material improves the long-term clarity and reduce visual disturbance, which improved material, especially stable acrylic lens, maintain the centration and reduce the IOL tilt or decentration. Blue light filtering material may reduce the glare and dysphotops in selected patient. Conclusion: better precautions in pre-op screening and immediate post-operative period saves the vision. Laser vision correction has shown a viable, non-invasive and accurate procedure for correct amyotropy after cataract surgery with IOL implantation. Lens-based procedure like a piggyback lenses are the possible alternatives. Piggyback IOLs technically easier, more accurate than IOL exchange. Improving outcome and patient satisfaction is a must. I thank the entire KSOS for this opportunity. Thank you, Anand.
It was a excellent talk. So in just to have one or two questions for discussion regarding post refractive surgery patients, which IOL do you prefer, and what is the because they have usually spherical aberration will be changed, corneal shape will be changed, higher order aberrations.
Yeah, post refractive surgery, normally we don't, before we never used to put them multifocals or patient with ring lenses, but now the advent of all these newer EDOF or advanced monofocals, I feel advanced monofocal by doing micro monovision, I personally feel better. But again, you need to work up the patient, even post refractive surgery, after pentacam, after eye trace, you calculate how much is the internal aberration. Then you decide. Sometimes even post refractive surgery also ring lenses you can still put. Again, depending upon how is the overall post-op outcomes, then you can take a call on that. But most safer. Not everybody will have eye trace. Not everybody will have pentacam. But okay, which is the best one? Someone comes. I think if the patient want a premium lens, much safer is advanced monofocal. So best is, I think you had already showed one of your slide. Patient, if they are undergone already refractive procedure for myopia, whether it is smile or whether it the LASIK. So either these kind of lenses, as Diksha said, that Rayner, that will do quite well with the patient. Those are already done with the hyperopic LASIK. But those who are already undergone, I'm giving the example, those are already undergone myopic LASIK, my preferred lens will be probably from Hoya, which is like the Hoya advanced monofocals. I think Vivinex. Those lenses really do well, and we have been also trying with some of the lenses from Indian make, especially from Biotech. So excellent lenses, set of lenses. The results are much better than any of the imported lens. Again, we need to look at what kind of refractive procedure they are undergone before. Depending upon that, then we have to select the lens.
Any take on this pediatric patients, sir? Do you prefer multifocal or?
Pediatric patient, depending upon the age, actually, we need to see. Um, to have like achieve a good to treat a kind of amblyopia, we have been uh, trying with this. Initially we started with a multifocal, but no, all this multifocal when you implant at the age of 10 or 12, suddenly the if eyeball start growing, then suddenly the baby might be having a very much residual error. So I think pediatric patient, younger patient, better to avoid this. Go with the monofocal. Later on, we'll have an option for them to have a this kind of any of the laser refractive surgeries. So for if they're having, see, one of the baby had come to me having a residual error for around the age of 14. They came to me of around the age of 20-25 now having a refractive error of right eye around 2.5 and left eye around 4. I did press band for them. Then patient, the boy, he was around 22 years. I did. He is very happy, having a good vision for distance and having a good vision for near. So again, type of refractor, better to avoid multifocal lens in the pediatric patient.